And I just wanted to start with a couple quotes. Louis Pasteur's quote that I got from the Brownson article: "To him who devotes his life to science, nothing can give more happiness than increasing the number of discoveries, but his cup of joy is full when the results of his study can find practical approach." And then I'm sure all of you know Lawrence Green's article about the 17-year Odyssey, where it takes 17 years to turn 14% of original research into some benefit to patient care. And you want me to try to take control again? Is that what we're doing here? Or
yes, go ahead.
You can just...
Yeah, you can move it, yeah.
You just have to click on the slide.
I'm clicking on the slide, and it's not going
forward.
So why don't give me control. You keep control, and I will just tell you when to advance it.
Sounds good.
Okay.
Okay. Okay, and many of you, I just took a picture out of this from the Lawrence Green article that shows that giant process from the priorities for research funding all the way up to practice. Okay, go ahead. So translating evidence into practice is really about, as many of you know, whose job is it? We make academic discoveries, we're supposed to put that research into practice, and then the population is supposed to improve. The health of the population is supposed to improve. Go ahead. Next slide. But back in 2013 in September, the American Journal of Public Health did a survey of 266 university researchers, asking them how much time they spend on the dissemination of their particular research, and 73% spent less than 10% of their time, and only a third of the respondents always or usually involve some level of stakeholders in their research. Next slide. Then at the National Cancer Institute, they had that wonderful Designing for Dissemination workshop. Every single participant acknowledged the importance of dissemination, but researchers reported that it was not their role to disseminate their research findings, and practitioners also did not believe that they were responsible for dissemination. So we had this giant, huge gap. If we're going to do this, how are we going to get this disseminated into the community? Next slide. So a great example that I like to show is if you were to look at the number of articles that have been published in the last 10, 15, 20 years even on obesity, they rise dramatically. And at the same time, the level of the number of articles, the level of obesity in our country is also rising. So one would expect at some point in time that there will be a coalescence on some of that research, and we will start to see this graph decline because so much research has been done, but it's not a very rapid trajectory. Next slide. So the Institute for Public Health was established at San Diego State University in 1992. I joined there in 1998. Its mission was to improve population health by translating scientific discoveries into the community in full partnership with community stakeholders. Next slide. So our goals were to serve as that bridge between academics and practice, and to promote individual, community, and system-level changes by working within the complex health and social service systems in our community, looking at health disparities, looking at health determinants of health, and trying to encourage practitioners to select evidence-based practices. And from the very beginning, in 1992, we were always a very community-engaged process. Next slide. So who do we partner with? And this is where we are a tad different than most investigator-initiated research projects. 80% of our projects are actually initiated by members of the service providers and members of the community. They come to us and say, what do you know about the evidence in obesity or lead poisoning or asthma or any number of things. We've partnered with hospitals, clinics, healthcare providers, primary care providers, and you can see that long list. We also don't believe that health is simply a matter of health care. So we've done a lot of work with law enforcement and with border health agencies and a lot of nonprofit organizations. Next slide. So many years ago, back in the very early 90s, we began by asking the community what the community needed from the university to improve their health. Next slide. And we did a number of surveys, and we did focus groups. And generally, the typical example was a request from a small local healthcare facility. This is just an example. Our small health center is a poor neighborhood, in a poor neighborhood, primarily serves Asian Pacific Islanders. We have a huge problem with obesity. Can you help us? And our usual response to that was to, first of all, find an academic expert in the discovery research that had a good understanding of obesity in this case, then to look for the characteristics of the organization and what they might be able to accomplish with the resources that they had, and then to partner them up with either ourselves or with the discovery researcher, seek funding with them, partner with them to accomplish the goals that they were looking to accomplish. This often involved showing them a number of different evidence-based best practices and having them help us to select which one they thought might work best for their community. So that was the number one question that they always ask us: what is likely to work best in our community? And they're looking for evidence-based practices. They want a lot of applied research. They, of course, want community-based participatory research. We did a lot of needs assessments in the early days. We did a lot of assistance helping them to establish and monitor outcomes and evaluate things. And we did just a tremendous amount of technical assistance in, how to build a database, how to build a research database, how to make sure that it becomes sustainable in your agency. And then we also learned that they had a lot of learning needs. So we developed a whole section that did distance learning, media technology, websites, that kind of thing. And we do a lot of convening of collaboratives in various content areas. Next slide. So this is just countries of origins of populations served by agencies partnering with the IPH. I like this slide because it shows the breadth of where the people in our community in San Diego come from. We have a very, very diverse community, lots of immigrants, of course, lots of people from across the Mexico border. Next slide. So all of you know the T definitions, the translational research definitions, the T1, discovery, basic, bench science, and then into the clinical trials and the efficacy studies. T2 is all about evidence-based guidelines, meta-analysis. T3 are those effectiveness studies from guidelines to practice in specific programs, specific nonprofit agencies doing specific things. And then T4 is about what does it take to get all of those agencies working together to improve the population's health. So for the vast majority of our time since 1992, we've been sitting right on T3 research, a little bit into T4 research, but we're really concentrating these days on T4 research and trying to build enough of effective programs in geographic areas to make some significant impact in the population's health. Next slide. So why is it so challenging to translate research into practice? You all know it takes a lot of scientific evidence to convince any academic that something is likely to work. Often these are expensive and very controlled clinical trials. The community is very frustrated with us in that regard. They want something faster, they want something easier, they want, to try to explain the challenges of actually learning that something works. And then they use a lot of what we call the gray literature, where just because it hasn't been tested by a researcher doesn't mean it doesn't work. I hear that a lot. And, scientific evidence is often collected under pretty perfect conditions. When I get some good money from federal government, for example, I can hire a lot of graduate students, I can hire statistical help, and, implementation is a lot messier than that. The context, the culture, the socioeconomic status, the neighborhood, the language in which the evidence is discovered in a clinical trial often doesn't match that which needs to be implemented. And the example that I always use is a program that we had in Southern San Diego County that was interested in violence prevention, and it was youth violence prevention, and the particular program that was the strongest evidence was developed among youth in Denver. And the community just couldn't say, they just said, it's not going to work. No matter how much your effect size is, it's not going to work for us because these are not our peeps, right? People. Scientific evidence is often developed without the input of the communities, and and we'll talk a little bit more about that. Okay, next slide. So here's part of the giant problem, and I know that you all know it. Funding from the NIH and federal government is content-specific, and it supports investigator-initiated research, and it's wonderful. I don't have any objections to it. I think we've done some marvelous things in our nation, and we're really good in terms of our strong academic support. But the problem is generally identified by the federal government or the funding agency, and then, you know, the RFA or the RFP comes out, and an investigator is interested in that research area, and so he or she does some wonderful work and finds the evidence. I know it works for this problem. And then it's essentially, please adopt this strategy because we know it works. And we're doing a lot more lately, but that's how it's been in the past. And when I ask my colleagues, how is the community going to adopt this strategy, those are the things they say. Well, somebody should pass a law and tell them that they have to do this. Or we should get insurance to pay for it, or maybe make the employers require it, or if professional societies recommended it, or journals publish it, if you sell it as a business product, those will all get it moving. But when you listen to the community side, and I know many of you probably have, they're going to say back to you, it just doesn't work for this. This thing that was built in this nice controlled clinical trial and your meta-analysis, it's too expensive for us, who's going to pay for it? It's not right for our culture. And then the one that is most challenging is it's not a problem for us, all right? There's money out there to implement an obesity intervention, but maybe obesity isn't our problem. Maybe asthma is the one that we want to concentrate on most. So next slide. So there is a common unspoken assumption underlying some of the federal monies, that the scientists whose careers have focused on the discovery of the new intervention should now also be responsible for studying their dissemination and implementation. And I see that in requests for proposals that come out where, you know, at the bottom, you've all seen it, at the bottom it says, you know, what are you going to do about disseminating this? And it's my contention that D&I research has to be considered its own academic discipline, and essentially, although many people have been doing this kind of work for years, it has to have its own place in a university. I think, can you just go forward one step? It's not the new slide, but yeah. So they're very different skill sets, discovery or T1 research and T3, T4. The field of dissemination and implementation research, including essential community engagement, is incredibly complex and expanding very rapidly. I don't think that we should expect traditionally trained T1 researchers to now become T3 or T4 researchers. We need to be specifically training T3, T4 researchers in their own academic discipline, in their own academic environment, with their own infrastructure, and then they're able to partner with those T1 experts. Next slide. So this is just those different skill sets laid out, and once again, I know you know that T1 needs to be content experts. They specialize in efficacy studies. They focus on the characteristics of the intervention and a lot of importance of internal validity and effect size and fidelity and a lot of academic audiences. The T3, T4 people, I think they need to be methods experts, and I think that from my experience, they can apply those methods to many different content areas. We need some alternate study designs. We work a lot on external validity. We're focusing on things that sometimes T1 researchers never even think about. What's the politics of this environment? What's the organizational structure? Where's the literacy? And different populations may need to implement differently to attain the same effect size. So interventions have to be tailored to achieve that. So I think the better combination is a T3, T4 partnership with a T1 partner. Forward, please. So the levels of change that we're considering is systems and environments, organization of the agency that's trying to implement something, a group or team approach, and of course, individual knowledge and behavior. Next slide. This is from Sarah Schnell's paper about sustainability of public health programs, which I gave you as one example of an article to read. These are the kinds of things we immediately consider when a community partner comes to us. Is there political support for this this evidence-based practice that they're looking for? Can they get funding and stability? Is the quality of the partnership good? Can we establish good sharing roles? Does the organization have the capacity? I mean, even just the data collection capacity of some organizations needs some assistance. Have we got a strong goal to evaluate how much adaptation needs to take place, who's talking to who? And then the public health impact is really important to these community neighborhoods. They understand what their problem is, and they don't always understand what to do about it, but they want a large impact. They want their programs, and we're talking to them more lately, not about single programs, but multiple programs in their neighborhood to actually show that the neighborhood is improving. And then there's always culture, language, and interpretations of health and disease that we need to pay attention to as researchers. Next slide. So new research methods are required, and I know you've heard this before. The gold standard of randomized control trials are wonderful, and they have extraordinary advantages, and they're wonderful for internal validity and optimal conditions. However, they don't often address external validity. They don't often work well for multi-level interventions. And as I said before, they take a long time to produce some answers. I've always found in my work and the staff at the IPH that adaptation and tailoring are often needed for these specific communities. We need designs that can assess the fidelity under these conditions and whether or not we're getting the same outcomes with our tailoring, or sometimes I've even seen us get better outcomes with our tailoring than the original intervention produced. And randomization is often not feasible or even acceptable in underserved communities with few resources, and we struggle with that a lot. This is from the Lansford paper in 2012. And these are just some examples of the D&I designs that we have used over time, and the purpose of this presentation is not to go through all the designs, but I can certainly talk to anybody about that if they have more interest later. Okay, so once again, I think a university infrastructure is specifically needed for D&I research, and I want to encourage the academic study of the translation of research to practice. I think that universities and other private or nonprofit research centers should consider establishing infrastructure specifically to develop these T3, T4 methodologies, and they don't have to be so closely aligned with content. Now, at the IPH, we have general content area researchers. We have one woman who works a lot in HIV/AIDS and infectious diseases. We have another investigator that works a lot with immigrant communities. So it's not like you take any old content that comes in, but I think that it's very possible for a T3, T4 researcher to work in many different content areas. So we need to get beyond the idea that those who create and initially test an intervention in the T1 arena are always the best to study its dissemination and implementation. Next slide. The advantages of the infrastructure that we've found at the IPH, a specific location at the university that community stakeholders know how to access and they have a history of accessing it. This relieves the stress from community stakeholders of having to search for a specific scientist with similar interests. Some of them, once they get to us, they say, man, I called all over, I called everywhere, no one would help me. But we knew at the IPH where the person was that was most likely to be working in the area that the community member wanted to work in. T3, T4 research is supported and recognized as a unique scientific discipline. I think that's really important. And I believe that for the search of federal funding, particularly the partnerships between T1 and T3, T4 scientists are going to improve the likelihood of successful proposals for funding. Next slide. More advantages, I think T3, T4 scientists foster long-term relationships with multiple community stakeholders in a wide variety of content areas. Many of our community partners, they're not disease-focused. They are neighborhood-focused, or they are institutionally focused, and they have multiple problems. So, for example, we established many years ago the Asian Pacific Islander Health Network in San Diego County, and when we first started, it was working on projects such as teen pregnancy and some STD work, and over the course of years, we've done a lot of different kinds of work, diabetes and asthma with this project, and now we're working on obesity with them. So these relationships build trust across projects and across time, and they don't disappear when the funding expires. In fact, those agencies are waiting for other funding opportunities and looking for other funding opportunities to do research in their neighborhood. The linkages to community collaboratives, advocates, and patients are then available to the entire university. I have faculty call me and say, my area of interest, let's just say, is asthma, and I want to do something with the community. Can you connect me up? And I have the resources to be able to pretty easily do that. And I know which agencies are more well-developed in terms of their ability to help conduct community-based kinds of participatory research and which agencies are not. I think the current system is both inefficient for community and inefficient for academics because each academic researcher trying to seek out their own community connection is inefficient unless they already have it. And many of them do already have it. I don't mean to imply that they don't, but some are seeking, and this is a nice mechanism to seek. Next slide. This is just some content areas of IPH research, and we have many of them, and we have D&I type researchers who have worked in all these different content areas with the methods, not with the content. We always partner with somebody who has the content much better than we do, but we have worked in all these content areas. Next slide. I think I gave you a little bit more, yeah, content areas. Okay, next slide. And then these are our ongoing IPH community connections or community collaboratives, and this is just a short list. So these are the top one there is the Asian Pacific Islander Health Network that I just mentioned. We also have a great African American health collaborative that we've worked with since 1995. Gay and lesbian community projects since about 1985. And Homeland Service providers, I've been working with them since the late 90s. So we have long-term relationships, multiple projects over time. Next slide. So the evidence these days is abundant. When I first started in this field, it was not abundant, and we were searching long and hard in individual academic journals about what is going to work in this community for this problem. But these days, as you all know, we have many sources of evidence, and I send students out to get it, and it's really not that hard to come by these days. Next slide. Okay, a little bit about the push versus pull strategies, and this is, I know you're probably familiar with these terms. If you are the developer of an evidence-based strategy and you want it to be implemented by the community, generally, you know, that's kind of a push strategy. Let me talk to the organization. Let me see how they feel about this evidence-based strategy. Maybe there's a couple that you might select from. And let me try to research what it takes to push that evidence-based strategy into the organization to adopt and sustain it. And then, of course, we're looking for improved outcomes. But at the IPH, we're really using pull strategies. So we have multiple organizations, and they have this, maybe they have the same problem, let's just say obesity, but the evidence-based practice that each one of them would use would be very different depending on who they are and their culture and what they're willing to accept and those kinds of things. So we have multiple organizations picking from a list, and then each one of them don't pick the same one. And so maybe one organization will pick evidence-based practice 1, and they'll get improved outcomes, and one will get evidence-based practice 3 with improved outcomes, and one will select something else and get no improvement. Or even you could try to implement evidence-based practice 1 in 3 organizations, and 2 will show nice sustainability and 1 will not. So you see that kind of variation with the goal of ultimately improving the population health. Okay, next slide. So let's just say you were a healthcare setting and you decided that you wanted to implement high blood pressure recommendations, and you wanted all of your providers across your whole agency to do that. So the idea is to train every provider in your healthcare setting that you want to implement these particular algorithmic ideas for the treatment of high blood pressure. And so that is a collective impact. That's the nurses are doing it, the doctors are doing it, physician assistants are all aware of it, and you would expect in that agency to have some improvement in blood pressure control. Next slide. But what we're reaching for, and could you just keep clicking in, what we're reaching for at the IPH is not just a healthcare setting, but a population. What is it that we need in a number of places? What do the schools need to do? What do the hospitals need to do? What do the produce producers need to do? What do the exercise people need to do in order to get these indicators to improve? Next slide. All right, so challenges for this infrastructure, and I don't mean to make it sound easy. Traditional T1 research asks the question, does this intervention work? What we're asking all the time is what are the factors that either encourage or discourage its adoption and its sustaining it that have been proven to work elsewhere. There is still, from my perspective now, a very large bias in medicine and public health for proving that new and innovative strategies work or discovering something new. And so if you're implementing a project that has already been proven to work in many, many different places, enough so that a meta-analysis said this works, there's some biases in the journals against that kind of thing. The one that is the fourth bullet here, and the one that always challenges us, is that federal funding is categorized by disease and communities categorize themselves by geography or culture or ethnicity or behavior or risk. They think of themselves as a group of people with multiple problems, not as a single person with a single problem. And so this creates a mismatch. And the good example is if I were to go to a community and say, what are your problems, they would list diabetes and heart disease and obesity in the same sentence. But a clinical trial doesn't go generally to the community. They are looking for groups of one person, at least one person from a lot of different groups to come and join their clinical trial. So they'll be seeking, if we do ethnicity, they'll be seeking white people and African Americans and Asian Pacific Islanders, essentially pulling them from their community to participate in this clinical trial on heart disease. And it feels like a mismatch to the community member. We need to answer the question. I have my opinion, of course, but we need to answer the question, is it essential that D&I researchers also be content experts? And then the last is, until federal funding for D&I research becomes more available, the partnering that we've done a lot of the partnering that we've done has not been federally funded, and then we run into the challenge of the lower F&A. Now, some universities have been more than willing to take less than full federal indirect F&A from organizations and foundations and things, and other universities have not. Next slide. These are all the people that have funded us in the past for various activities. So we have federal funding, but then we've also had very small amounts of funding from the Asian Pacific Islander Health Center Awareness Network, for example. Next slide. Once again, next slide. Okay, some really unique challenges for this kind of work, and I alluded to it earlier, the long tradition of investigator-initiated research. I'm looking, what if investigator-initiated research doesn't match the needs of the community? Could the federal government find a mechanism to encourage community-initiated research questions? Even CTBR, which I love, tends to begin with the interest of an academic and their funding sources and then flows into the community. How do we get the community voice a little louder? The publication of results, as I mentioned before, many journals are still seeking new and innovative intervention results. When I take an evidence-based practice that I know has worked and has been shown in a meta-analysis to work, and I put it into a community in their practice setting, not with a lot of students, but in their practice setting, not with a lot of resources, and I get the same effect size as the original article. I'm so happy I can hardly stand it. But the journal will say to me, well, you didn't get an effect size any better than what they got in this other place that was in a clinical trial, and that's challenging. Another challenge is many community partners would prefer that their results are not published in academic journals, and this is a really big problem for academics because if somebody in the community comes to the IPH and says, we have this giant problem, and then the IPH helps them to solve their problem, do they want it published that they had this giant problem in the first place? And that's huge. And many other authors have talked about alternate forms of dissemination research results that need to be recognized in faculty promotion decisions. And then my favorite, you're not doing real research. I haven't quite figured out what real research is to some people, but I think it kind of falls along the line. Is it's not federally funded and it's not a clinical trial. Next slide. Okay, I want to finish up with some comments about a community engaged scholarship, because every one of our pieces of research is community engaged. Next slide. The foundations for community engagement, I know many of you are probably doing community engagement, but all communities have their own identity and a very good understanding of their strengths and weaknesses. You need, as a researcher, to learn those up front, because interventions most likely to work have to fit that local population and their understanding of themselves. You have to build on the strengths of the community as they are understood by the community, not as they are understood by the researcher. And you have to enhance or improve currently existing systems. The best sustainability that we've ever found is in agencies where we can embed the research results and the findings right into their current way of doing things. Collaborative equal partnerships between academics and community members in all phases, and that resonates with CDPR. And then the bidirectional learning and capacity building. And I've just said it many times, but I can't tell you the number of times that I've looked at the data collected in these ways. I thought I understood it. I've taken it back to the community partners, and they will say to me, I understand that these are the numbers, and I agree that these are the numbers that are correct, but you're interpreting it wrong. Next slide. I think all types of research are enhanced and improved by community engagement. That's just my bias, T1 to T4, but I think T3, T4 research can be done without excellent relationships with community partners. Next slide. I'll finish up with my favorite little example. Go ahead and move forward a little. This is John Snow, the father of epidemiology, and as you all remember, next slide, he was the one who is given credit of reducing a cholera infection in 1854 on Broad Street in London. 600 people died in a week of cholera from the water coming out of a particular pump on Broad Street. This little map, this is the first epi-map ever made, and what he did beautifully is show where all the people lived who died. But what he didn't know at all was which people were drinking out of which well, because there were, a dozen or more wells throughout this neighborhood. And he didn't know the answer to that, and there was no way that he was going to figure it out, because most of the people had left Broad Street and gone to the mountains because they were afraid of this disease. So in comes the next slide. And keep going forward. Here's this wonderfully looking fellow called the Reverend Henry Whitehead with his beautiful beard. He was a priest, and he had his church on Broad Street. And he did home visiting from his church, and he happened to know that every single person which pump they were using. So he and John Snow were able to get together to actually eliminate the cholera epidemic on Broad Street. It's one of the first epi studies ever done, and community engagement was occurring at that time. Next slide. Okay, just a couple finishing up slides. What we're trying to do here at the IPH now, I told you that we're trying to move from T3 to T4 research. So with the help of the UCSD CTRI, we're seeking to put together an interactive public use web portal, kind of a community indicators project that's going to display population health indicators geographically, evidence-based practices that might help with those indicators. We're also going to display the community resources that are available currently in our town to address those indicators, and the local researchers at SDSU and UCSD whose work could actually affect those researchers. We're hoping that that infrastructure will then help us to connect researchers to practitioners in specific content areas. We're going to also offer some training and technical assistance to do some, hopefully, some high-quality dissemination and implementation and get some more researchers trained to be able to do that. Next slide. Okay, I think this is the last slide. So this is what we're talking about. We're going to try to put up local actionable indicators, which means that a community member could get on a website and say, oh, I could do something about that. Local social determinants of health overlaying those indicators, who's doing what work in the neighborhood, and then evidence-based practices that might be appropriate for those neighborhoods, and training in those practices, and hopefully looking for measurable local population health improvement. Next slide. I think that's the end. Okay, how did I do on time?
That's perfect, thank you. Thank you. It was great. Thank you. Dr. Midman, are you still on the line if you want to start the Q&A session? Or?
Yes, I am. So you can go ahead, and I actually have a couple of questions, Sue, while others are unmuted. First of all, thank you for the wonderful presentation, very nicely organized and delivered. So it seems like the Institute for Public Health is a relatively innovative activity. The only comparable program that I'm aware of is actually similarly named at the Washington University in St. Louis. My question is, what have you done, if anything, to disseminate and help implement this idea? Are there others that you are aware of, and is there any effort to try to stimulate the development of similar initiatives at other campuses?
Well, this is, I'm trying to take it out on the road. This is one of my actual first efforts. We have spent enormous amounts of time over the years with each program, as I told you, with each program trying to put evidence into their systems. And I think, I think we have a mechanism that works. I think it has some challenges, as I said, but I'm trying to now, with this group and with other groups, to try to see if I can't promote it more.
Okay, now a somewhat related question, and that has to do with the idea of the respective obligations, roles, and responsibilities of different investigators. Could you talk more about the distinction and how you view those responsibilities for dissemination of research findings, for implementation of research findings, and for the dissemination and implementation science activity? And I think I would distinguish between those three. And it may be that we would expect different things from our predecessors on the pipeline in those three different categories.
I absolutely agree with you. And in the early days of the IPH, when our role, that was before we even talked about dissemination and implementation, of course, it wasn't even really a buzzword. What we were mostly doing is how do we help the community with what the community needs. So we did a lot of just plain old simple dissemination. This could work. Then we moved slowly into let me help you implement this with the academic knowledge that I have. And it's only been really in the last 10 years or so that we have realized that we need D&I research skills to actually train people in that single methodological area of expertise. And honestly, I kind of waffled around for years with, are we content experts or are we method experts? And if we're method experts, is the general academic community going to accept us? Because the academic community tends to like the content experts, right? But I think that we need this group of researchers, and I'm working with the UCSD CTRI to put some trainings together for their students and some trainings together for my students, specifically to get this type of methodology in place. Mm-hmm. And then, of course, we have to go with who's going to fund that alone. And I don't think it should be funded alone. I think a T1 researcher and a T3, T4 should partner.
Sure. Okay, thank you. Ibrahim, are others off mute? I'm more than happy to continue to ask my questions, but we should open up the floor.
Yeah, so what we're going to do is that if you have a question, you can either type it in the chat or raise your hand. You can click on the raise your hand button by right-clicking us to your name, raise hand, and we can unmute you. Because I don't want to unmute everybody because otherwise we would have too much echo on the line.
Sure.
If you have a question, just type it on the chat or just raise your hand.
So, Sue, let's give other folks a few seconds. And if there's too much silence, I'll chime in with what I think may be a brief follow-up question.
Or even just feedback. I'd love some feedback on what you think, in conversation and dialogue.
So while we're waiting, my question actually is a bit of a question and feedback, and that is, given the power of this idea and approach, My question is what we can do, your counterparts and colleagues in this Southern California regional collaboration that we're in the process of establishing, what can we do to help?
Well, what I would like to do is have some kind of a working brainstorming session at your upcoming conference. I would like to sit down and talk to you about what you think about this and how it might work. I mean, there's really three things going on: the training of methodologists, the more of the community's voice up at the federal level, right? And then the work itself of writing the papers of what it takes to get this stuff sustained in the community. And that's a lot of work.
Sure.
And I would love to have the conversation about how we get there.
Okay. So that's a topic that we could possibly set up as one of the parallel topics for the afternoon brainstorming session, that period of the meeting. Ibrahim, are there, I'm not sure if I can see typed questions. Are there any questions from the participants?
No, nothing has come from the participants for now.
Okay.
Can I ask anybody on the line whether or not it seems totally unfeasible to them, or how does it feel? Nobody wants to help.
I've been trying to ask a question, but I'm not sure if I'm couldn't figure out a way to raise the hand, and I'm not sure if this is going through at all.
Yeah,
Can people hear me?
We can hear you, so fire away.
Okay, yeah. So I was just wondering, sort of at SDSU, are there efforts to sort of implement sort of dissemination and implementation training? Are there sort of coursework or sort of training opportunities for students to gain some expertise in these methodologies?
Yes, we're developing that right now, and I know if any of you know Greg Ahrens, he's quite good in that area, in the area of mental health, organizational structure for interventions into mental health interventions for youth usually. And he and I and a few other folks are working really hard right now to establish a training program specifically for D&I researchers. UCSD as well.
Thank you. I mean, it really seems like an unmet need, and I think that's something that we can use at UCLA as well, given the, attention that is given to this field with NIH and other funding sources. So thank you so much for your presentation and sharing with us.
And the funding sources are increasing. We now have the new D&I Institute, we have the CORI, we have the comparative effectiveness. Those sources of funding I think are strong for this type of work. So I think it's growing.
But I think the hybrid of academic research and policy and practice-oriented activity, as you presented it, we know is a bit more of a challenge for many of those sources. And PCORI remains, at least in this area, a bit of a work in progress. With new staff, in a new direction, we will have to see what emerges from that institution as far as the criteria for projects that they will support in the mix of the pure science and the more policy and practice oriented activity.
Exactly.
Others from the attendees, especially those from other institutions, are there discussions underway within your campuses, institutions to set up a similar program? And again, Sue, as we are waiting, have you reached out to your counterparts at WashU in St. Louis, or are there others that you are aware of that could help you both with, the roadshow aspect as well as the related efforts to, attract more interest, funding, support, legitimacy for this kind of activity?
We've reached out. There are occasional small clusters of groups of people at universities who are interested in this kind of structure, but it is a little different, and it is a little. It's non-traditional. So there's some fear about, well, would anybody ever fund this, and how would they fund it, and that kind of thing. And so I have not been with Washington University, but I was actually just reading about them yesterday. So,
so that may be a useful contact. The related question is to what extent the state funding for San Diego State University is an important factor, or is this something that you could see gaining support at private universities as well?
Well, I think it could gain support at any university. When the IPH first started in 1992, it was funded in part by the university and in part by the Graduate School of Public Health had some funds. But since that time, and particularly with the bad economic crash that we had, that external funding went away. So we've been supporting ourselves on these partnerships with community agencies since, let's see, late 90s. So we're standing alone. And, you know, we have a lot of community support in terms of willingness to fund these kinds of applied activities and understanding of how to do this right. So that's excellent. And the new web portal concept that we're working on with CTRI funding is a very broad brush of the hospitals, nonprofit organizations, the county, health department, the two universities. So we're hoping to get some nice funding source to keep that one up and running.
And that too is an idea that would be nice to discuss or to see an illustration at the March symposium.